presentation you have.
يتفضل زيد.
Okay, now start. Case presentation: 10-month-old infant presented with abdominal distension and elevated liver function test. Sent for ultrasound. On abdominal ultrasound, right transverse section show this view and left transverse section showing this view. And sent for CT scan with contrast for further evaluation. This is the axial section.
على كيفك، لا تمشي بيه سريع.
نعم أستاذ. This is the contrast.
صابري.
نعم أستاذ. The CT scan of the abdomen, multiple section CT scan showing enlarging of the liver and both kidney associated with the dilated, diffusely dilated intrahepatic duct, and after contrast enhancement showing what's called the central dot sign, which is representing the portal radicals. Differential diagnosis of this case according to the age. يعني دكتور ممكن نخلي polycystic مثلا liver disease، مثلا ممكن نخلي
وين السنترال دوت ساين؟ والله شفناها بالاكزيل موجوده واضحه.
يعني دكتور مو كلهم بس some of them، أي مثل هاي مثلا ايه بالضبط بالضبط.
فthis is massively enlarged liver, enlarged kidney.
both kidneys.
ودايليتد severely dilated or ما severely dilated intrahepatic bile ducts more on the right side.
صحيح.
نعم. شنو هذا الفلين ببالك؟
يعني دكتور هو according to the يعني to this feature according to the central dot sign هو يمشي spot diagnosis للكاروليز disease especially مع الستيت of the kidney، لأن الكاروليز يصير ب association إنه مثلا kidney إنه medullary sponge kidney أو autosomal dominant or recessive polycystic kidney disease فيمشي وياه. بس بصراحة ال presentation at this young age يعني شوية strange to me، إنه يعني بنحس إنه يعني so young البيشنت إنه 10 months.
زين، احتمال آخر شنو عندك؟
يعني إذا نفكر مثلا بالبوليسيستيك ليفر ديسيز ما يصير بالسنترال دوت ساين افتر كونتراست انهانسمنت. اذا نفكر مثلا انه بايوجينيك كولينجايتس البيشنت ككلينيكال يعني هيستوري ما عنده مثلا فيفر ما عنده جوندس، هو قال انه فقط ابدومينال ديستنشن واليفيتد ليفر انزيم.
نعم. والكدني بس انلارج،
يعني الكدني اللارج وابنورمال كورتيكال يعني ابنورمال انهانسمنت. ايه يعني حتى يعني query about يعني their functioning يعني إذا بحالة مسوي له مثلا real function test أو لا دكتور زيد؟
نعم دكتور، هي elevated يعني.
أي فيعني حتى ال functioning of the kidney يعني يعني affected، فمعنى هذا يمشي أكثر ويا الكاروليز.
نعم. ماشي، شكرا صابرين.
شكرا أستاذ.
دكتورة تراث جاسم.
نعم أستاذ. نعم أستاذ، صباح الخير.
صباح الخير، هلا تراث. شنو رأيك تراث؟
نعم، مثل ما قال الدكتور الصابري there is a bilateral a large kidney with a hugely dilated and large liver, and there is a dilated intrahepatic biliary tree, cystic dilatation of intrahepatic. Some of these cysts explain central dot sign which goes with a Caroli disease, and there is association. هو اكو عندنا association between the Caroli disease and the liver disease, cystic liver disease mainly يعني ويمشي ويا age of the patient, a small age autosomal recessive Polycystic disease. طبعا بعد نحتاج انه شوي delayed phase to see the excretory phase of the kidney, function of the kidney. وطبعا اكو هي
الكدني بيها
relation
سيست لو ما بيها سيست برأيك؟
يعني هاي ما بيسس احنا هذه corticomedullary phase، يعني بعد ما نقدر نميز انه هذا يكون enhancement of the medulla or medulla or not.
تمام. شنو
بس احنا شفنا
الابنورماليتي اللي بالكدني غير الانلارجمنت؟ شنو الاذر ابنورماليتي بالكدني؟
عفوا استاذ، احنا
وقف على الكورونا.
شفنا بالالترا ساوند
اي
انه there is no cyst، يعني just hyper echoic and enlarging in size.
نعم. لا، اكو ابنورماليتي بالكدني اللي هو اول شيء اللارجمنت، وبعد
Yes, enlargement. يعني ما عندي فكرة انه بعد
اكو
شنو
ابنورمال
عندنا.
اكسس، مو اكو ابنورمال اكسس اوف ذا
Yes,
كدني، ما
yes,
روتيشن.
yes, frontal orientation
نعم.
of the renal pelvis.
نعم، هو كلش
هو طبعا
قريبات الميديال بول كلش قريبات، لكن ماكو يعني انه فيوجن.
ماكو فيوجن. يس. وهو دائما احنا بالهيك يعني هيك كيس انه اوتوسومال ريسيسيف بوليسيستيك كدني ديزيز تكون ريليشن هي ريفيرس، يعني بين الليفر فايبروسيس وبين بحاله اذا كان عندنا suspicion of the liver fibrosis نتوقع انه البيشنت may be complicated by portal hypertension.
نعم. هو هذا الاستدي المفروض اكو بعد فيس اخر بالكونتراست حتى نشوف البورتال فيس ونشوف الاكسكريتري ايضا، الديليد فيس.
الاكسكريتوري يس ديليد فيس.
شكرا تراث. يلا زيد احكي لنا شنو عندك
عفوا.
الكيس هذا.
نعم
السلام عليكم أستاذ.
عليكم السلام، تفضلي.
أستاذ، بالنسبة للبرزنتيشن هذا الكيس هو يعني يعتبر كارولي سندروم لأنه associated with autosomal recessive kidney disease. فالبرزنتيشن هو يكون بالعكس، يكون early presentation، يعني الكارولي سندروم rather than كارولي disease اللي يبقى شوي التشايلدهود والادلتهود. فبالنسبة لهذا الكيس أنا يعني مرة هم باليرموك شفت كيس دزوا عليه بالنسائية when يعني 2 hours يعني نيونيت 2 hours كان نفس الفايندينج typical نفس الفايندينج died in the same day، يعني died. بعدين سألت الأوبستريشن قالت لي هذول أغلبهم الكوز اوف داينج مالتهم هو البالمونري هايبوبليجيا. فيعني الكارولي سندروم هو presented early. شكرا أستاذ.
وعادة الاوتوسومال ريسيسيف بوليسيستيك كدني ديزيز عادة يقولون موستلي انكومباتبل وذ لايف، على عكس الاوتوسومال دوميننت اللي هو هذا.
بالضبط يعني هذا الزين هو باقي لل10 اشهر.
نعم.
شكرا أستاذ.
شكرا شيماء. يلا زيد كمل عين.
نعم أستاذ. some حقيقة two siblings male about يعني same age they are presented يعني with يعني liver failure hugely enlarged liver both of them ويعني attenuated portal vein was by ultrasound. The ultrasound images show the central dot sign as seen by the presentation before and spleen still not enlarged that يعني يعني very dyspneic tired patient يعني والkidneys both يعني large in size و echogenic. يعني هي كارولي كيس اوف كارولي سيندروم يعني at the start يعني بعدنا ما داخلين بالهيباتيك فايبروسيس وتوجذر يعني ويا الاوتوسومال ريسيسيف بوليسيستيك كدني ديزيز.
يلا سوي شو بابا.
نعم.
تفضل.
So, Caroli disease, it's a congenital condition. It's a non-obstructive dilatation of the intrahepatic bile ducts. Usually it comes either as a diffuse type or a focal type. In the focal type, as seen here by this image of contrast-enhanced CT, we can see the focal type, and this is a dilatation, autopsy image showing the dilatation of the intrahepatic biliary tree. So Caroli disease, it is a spectrum of fibrocystic liver diseases, ranging from Caroli disease to Caroli syndrome to the multiple biliary hamartoma. As we see by this image, Caroli disease usually affecting the larger intrahepatic bile ducts, while Caroli syndrome affecting the more distal, smaller intrahepatic bile ducts and associated with congenital hepatic fibrosis and end with liver failure. And also we have the last part of the spectrum, multiple biliary hamartoma, the von-Weinberg complexes. So Caroli disease, as I said, is limited to the dilatation of the larger intrahepatic bile ducts, while the Caroli syndrome is a combination of small bile duct dilatation and a congenital hepatic fibrosis. Both are rare autosomal recessive disorders with a slight female predominance, and they are named after Jacques Caroli, which is a French gastroenterologist who described it in 1958. Okay, this is a case of Caroli disease. As we see, this is an first image. We have unenhanced CT scan showing multiple gallstones within the dilated intrahepatic bile ducts. And this is an XZLT2 weighted MRI showing multiple hyperintense cystic ectasia with a calculi. And this is a coronal MR cholangiogram showing the dilated intrahepatic bile ducts with multiple stones seen within the dilated CVD, which are formed intrahepatic and pass to the CPD, or this cystic dilatation communicating with the major biliary tree. So Caroli disease and Caroli syndrome are congenital disorders, consist of a multifocal cystic dilatation of segmental intrahepatic bile duct, and they are classified as a type 5 choledochal cyst according to the Todani classification. So Todani classification of the choledochal cyst, we have type 1, which is the most common type, 80 to 90%, which is the dilatation of the extrahepatic bile duct only. We have type 1A cystic, vesicular, 1C is pisiform, and we have type 2, so this is the type 1, dilatation of the extrahepatic bile duct with different forms. Type 2, it is a CVD diverticulum, usually in the supraduodenal portion. Type 3, we call it choledococele, which is involving the intraduodenal portion of the CVD. Type 4, which is the second most common type, 10%, is intra and extrahepatic bile duct dilatation. Type 4A is intra and extrahepatic dilatation, while type 4B is multiple extrahepatic dilatation. And type 5, our subject is the Caroli disease, which is rare, involving intrahepatic ducts only. So this is image showing the Todani classification. This is type 1, which is a pisiform dilatation involving the extrahepatic CVD. This is a diverticulum of the CVD in the supraduodenal portion. This is type 2 Todani classification of choledochal cyst. And here we have the choledococele, which is type 3 by the MRCP and cholangiography. And this is the type 4, which is intra and extrahepatic bile duct dilatation. So the clinical presentation, they're usually presenting in childhood or young adult. Actually, Caroli syndrome, which is associated with liver failure, it usually have more childhood onset of presentation, while Caroli disease involve the young adult presentation more common. So they're usually presenting with Caroli disease with the right upper quadrant pain, with the recurrent gallstone, pharyngitis, fever, and jaundice. While Caroli syndrome, they're presenting with all these symptoms along with the signs of portal hypertension, hematemesis, melena, secondary to abdominal varices. And usually the first symptoms typically including fever, intermittent abdominal pain, enlarged liver, sometimes jaundice develop. And Caroli disease usually occur in the presence of other diseases like autosomal recessive polycystic kidney disease, pharyngitis, gallstone, biliary abscesses, sepsis. These may be a complication. And liver cirrhosis, renal failure, and cholangiocarcinoma, 70% affected. People with Caroli disease are at 100 times more risk of cholangiocarcinoma than the general population. Okay, this image showing the embryonic development of the ductal plate, and it will describe the pathogenesis of central dot sign. So this is ductal plate malformation. During early embryonic development, there is a single layer of ductal plate surrounding the portal vein, as we've seen by figure A. And then followed by the formation of a double layer plate with a cyst-like primitive bile duct lumen in figure B. This is a second layer, and this is a cyst-like bile duct lumen. And there will be extensive resorption of these primitive bile duct to the final stage, in which a network of fine bile duct is surrounding the portal vein, as seen in C. Okay, any insufficient resorption of these bile ducts or the ductal plate, it leads to a large dilated segment of the primitive bile duct surrounding the central portal vein, as seen by this image in figure D. We see there is incomplete resorption of the ductal plate due to the formation of this we talked about, which is the central dot sign seen by imaging. So pathologically, Caroli disease and Caroli syndrome are a group of spectrum fibrocystic liver diseases resulting from in-utero malformation of the ductal plate discussed before, and there is high association with a fibrocystic anomaly of the kidneys, which share the same gene defect, the PKHD1 gene. So Caroli disease, which is the simple type, resulted from abnormal development of the large bile ducts, while Caroli syndrome, the preportal type of Caroli disease, both involving the central intrahepatic and the ductal plate of the smaller peripheral bile ducts, so it will lead to the development of fibrosis. At the other end of the spectrum, we have the von Weinberg complexes, which are biliary hamartoma that result from discrete foci of ductal plate malformation, usually affecting the smallest bile duct. Again, this is showing the ductal plate formation early embryonic life, and this in late gestation. And this is the normal mature pattern of the bile duct. And this is a case of a ductal plate malformation, a failure to do differentiation of them lead to the formation of Caroli disease. What are the associations? Usually, simple Caroli disease is actually uncommon, occur more frequently with congenital hepatic fibrosis forming the Caroli syndrome. Usually associated with medullary sponge kidney, about 80% of cases, and autosomal dominant polycystic kidney disease or autosomal recessive polycystic kidney disease, as seen by this image. Simple talk about polycystic kidney disease. We have our childhood polycystic kidney disease, usually autosomal recessive, and mutation in this gene which is shared between the liver and the kidney. So it's usually associated with a kidney problem, Caroli disease. Usually present in infancy with renal insufficiency associated with multiple hepatic cysts and congenital hepatic fibrosis. Grossly enlarged bilateral kidneys with small cysts in the cortex and medulla at having their long axis at right angle to the capsule. While autosomal dominant is more adult onset than middle age, presenting with hematuria, hypertension, UTI, and even renal stones, and have association usually with perianeurysm and mitral valve problems. The radiographic feature of Caroli disease. The disease may be diffuse or may be lobar or segmental. The dilatation is more frequently saccular rather than a physiform dilatation, and this is a feature important to help in the differential diagnosis. By ultrasound, we will see the dilated intrahepatic bile ducts, as we see by this image, and the intraductal bridging, as we see by the pathogenesis of ductal plate. We can see echogenic septa traversing the dilated bile duct lumen due to incomplete resorption. And we have here the small portal vein branches partially or completely surrounded by the dilated bile duct, which here the central dot sign, we call it intraluminal portal vein sign, which is a dilated duct surrounded by the portal vein. Here's the portal vein bicolor Doppler taking vascularity, and this is the surrounding dilated intrahepatic ducts and intraductal calculi. And this is by ultrasound image showing dilated intrahepatic bile ducts with the intraluminal portal vein sign. And this is contrast enhanced CT scan showing the central dot sign, which is the enhancing echogenic dot, enhancing dot of portal vein surrounded by dilated intrahepatic ducts. And this is T1 and T2 weighted MRI showing also the central dot sign, which can be seen by almost all imaging modalities. And there is here multiple intraductal stones. So always remember, Caroli disease, the spot diagnosis, central dot sign is seen in this disease, and it is a type 5 polyductal cyst. By CT scan, dilated intrahepatic duct will be seen as a hypodense round area, inseparable from other dilated intrahepatic bile duct. And central dot sign, as we said, are enhancing ducts with dilated intrahepatic duct representing the portal radicals. By MRI, we see it as T1 hypointense, the dilated intrahepatic ducts, and T2 hyperintense. And with gadolinium, we can see the enhancement of the portal vein radicals within the dilated intrahepatic duct, which is the central dot sign. The MRCP and the RCP, they will demonstrate the continuity with the biliary tree for confirmation. Regarding in nuclear medicine, intrahepatic bile duct can have a beaded appearance as seen by HIDA scan. Regarding the treatment and prognosis, prognosis is poor usually. If the disease is localized, segmentectomy or lobectomy may be enough. In diffuse disease, they usually conservative measure first and liver transplantation later on may be an option. What are the complications? We have the simple type, the Caroli disease, the intrahepatic stone formation, recurrent cholangitis that lead to bacteremia and sepsis, and hepatic abscesses also may develop. Periportal fibrosis type, which is the Caroli syndrome, they usually end with cirrhosis and portal hypertension, hepatomegaly, ascites, varices, all the stigmata of chronic liver disease. And there is also cases of cholangiocarcinoma developed in 7% of cases. This case imaging showing the congenital hepatic fibrosis in a patient with Caroli syndrome. We will have dysmorphic liver, irregular capsule, enlargement of the left lobe, usually with a right lobe atrophy, enlargement and abnormal branching of the hepatic artery, dilated splenic and portal veins as portal hypertension, and scarred and fibrotic kidneys. This picture showing the complications of Caroli disease. As we see here, we have an intraductal stones. Here, the intraductal stones passing throughout the CBD in the MRCP. And here we have an enhancing mass with delayed washout of contrast by CT, suggesting the development of cholangiocarcinoma. Cholangitis, here we have the thick wall intrahepatic bile ducts, and usually have irregular contour, and sometimes there will be development of cholangitis abscess and liver abscess as a complication. So how to evaluate a patient with Caroli disease? Usually we start with symptomatic treatment. Usually it is conservative. For the cholestasis, the main problem is the cholestasis. So there will be superadded infection, stone formation, destruction of the biliary tree, more and more. So we give the orcidiol, which is a choleretic, enhances the execution of bile secretions. Cholangitis can be treated by endoscopic stone extraction, lithotripsy, and PTC. The symptomatic Caroli disease, if it is reflective to this conservative treatment, according to the presentation, if the patient is monolobar disease without portal hypertension, partial hepatectomy, segmentectomy may be enough. If with the development of portal hypertension, whether monolobar or multilobar, it will end with liver transplant. And if the patient develops cholangiocarcinoma, liver transplantation is no longer recommended. Treatment depending on clinical features and location of biliary abnormality, antibiotic to treat inflammation, also for the hepatolithiasis, and diffuse type, conservative first, and then liver transplantation will be an option. So differential of Caroli disease. This image shows the differential diagnosis at the level of the intrahepatic ducts. As we see, Caroli disease involving the larger intrahepatic ducts, while Caroli syndrome will involving the more distal, smaller intrahepatic ducts. And we have this autosomal polycystic liver disease. We have multiple cysts that will show no communication with the biliary tree, and his multiple biliary hamartoma that occur more distally. So polycystic liver disease, not associated bile duct dilatation and rarely communicating with bile ducts. We have peribiliary cyst, choledochal cyst, biliary hamartoma, which can be cystic and important to differentiate from cystic metastasis. Primary sclerosing cholangitis, which are dilatation usually more pisiform, while Caroli disease is usually more saccular and associated with inflammatory bowel disease in 70% of cases. Recurrent pyogenic cholangitis, which is presented with sepsis and biliary dilatation and saccular dilatation favor the Caroli disease. And the obstructive bile dilatation. This is showing the image of differential diagnosis. This is a choledochal cyst, this is multiple biliary hamartoma, and this is a case presented with fever and rigor, so recurrent pyogenic cholangitis with the development of stones. So what is the differential diagnosis of intrahepatic bile duct dilatation? Either non-obstructive type or obstructive type. Obstructive is either stones or structure, whether benign or malignant. While the non-obstructive type, we have the Caroli disease, choledochal cyst, recurrent pyogenic cholangitis, and primary sclerosing cholangitis. But differentiation between both is clinical. So shortly about cystic lesions of the liver, I will talk about them. We have many types. Developmental cystic liver lesion, I will talk about this in brief. Infectious, inflammatory, neoplastic, post-traumatic, and miscellaneous. So developmental cystic liver lesion have biliary hamartoma, benign hepatic cyst, Caroli disease we talked about in details, and the polycystic liver disease related foregut duplication cyst. So biliary hamartoma, they are resulting from embryonic bile duct remnant that fail to involute. They are benign and asymptomatic, may be found incidentally on autopsy or at laparotomy. Imaging finding the usually well circumscribed lesion with echogenicity depending on the content, And usually they present on CT as multiple hypodense lesion less than 1.5 cm and margin more irregular than simple hepatic cyst. And by T2, they are hypointense on by MRI, hypointense on T1, hyperintense on T2, and on heavily T2-weighted MRI images, they will show signal intensity increasing further, almost reaching signal intensity of the fluid. So the MRCP show multiple small cystic lesions do not communicate with the biliary tree, and sometimes punctate calcification on CT. So this is a case of multiple biliary hamartoma in a 35-year-old woman. This is by T2-weighted MRI showing tiny hyperintense round lesion throughout the liver, and this is by ultrasound showing multiple echogenic foci with comet tail artifact. This is also coronal T2-weighted MRI showing the multiple biliary hamartoma, and this is also seen by MRCP. So biliary hamartoma, to differentiate it from Caroli, no communication with biliary tree, unlike Caroli, less enhancement than cystic metastasis, and asymptomatic, unlike the microabscesses which occur mainly in immunocompromised. Benign hepatic cysts, they are congenital biliary malformation. They are benign, asymptomatic, usually need no treatment, or asymptomatic, percutaneous drainage with sclerotherapy or surgical resection. By imaging, by ultrasound, we see an anechoic with regular, well-defined margin with posterior plastic enhancement. By CT scan, also well-defined, homogeneous, without contrast enhancement. By MRI, hypo on T1, hyper on T2, and characteristically show signal intensity, increased signal intensity on heavy T2-weighted MRI. This helps to differentiate it from hepatic cysts that are usually malignant, which appear less intense on these sequences. So this is a simple hepatic cyst. We see posterior acoustic enhancement. This is a contrast enhanced CT showing simple hepatic cyst. So how to differentiate it from Caroli disease? Absence of communication with the bile duct, unlike the Caroli disease, large potential size and more variation than biliary hamartoma. Absence of enhancement, unlike cystic metastasis. Caroli disease, we talked about in details. And polycystic liver disease, genetic mutation which causes malformed small intrahepatic ducts to lose their communication with biliary tree, usually presenting with pain, abdominal distension, and ascites. Treatment, if symptomatic, transplantation may be considered in patients with loss of normal liver function. By imaging, this is important. Multiple intrahepatic cysts, peripherally located, vary in their size, and the peribiliary types are usually small, less than 10 mm, and have perifocal distribution. On CT, you can see fluid level, wall thickening, calcification, or internal gas. And best imaging modality to identify the cyst complicated by hemorrhage or infection is by MRI. So this is a case of autosomal dominant polycystic liver disease in a 40-year-old man with a non-polycystic liver disease. By T2, we can see numerous cysts of variable sizes throughout the liver, and peripheral incomplete septation are seen here. Okay, and this is also a transverse ultrasound image of the liver showing multiple anechoic cysts with echogenic septation. Also, this is contrast enhanced CT scan in a patient with polycystic liver disease. Multiple simple cystic lesion of the liver and kidneys, as we've seen here. And also there is by image B, we have numerous cysts in the left lobe of the liver. Some of them they have polygonal borders. So the differential diagnosis is by absence of communication with bile ducts, unlike Caroli, and large potential size and more variation than biliary hamartoma. The last topic is ciliated foregut duplication cyst. It's rare congenital cystic lesion that occur a ruminant of the embryonic foregut, asymptomatic incidental discovery. Given the reported risk of malignant transformation, they should be resected if they are symptomatic, enlarging more than 4 cm, or containing a typical feature like solid component, thick septations. They should be resected. On ultrasound, they are usually very small lesion, less than 10 mm in segment 4, anechoic or hypoechoic. On CT, density depending on their serous or mucinous content. So this is an example of a ciliated cyst in a woman, 76-year-old. Ultrasound showed the hypoechoic lesion with a posterior acoustic enhancement. These are the references, and thank you.
شكرا.